Hit the subscribe button or visit us at auau.auanet.org.
Good afternoon, everyone, and welcome to AUA's Engaging Disparities in Prostate Cancer live webinar. We strive to offer outstanding educational courses and greatly appreciate your evaluations and general feedback so that we are able to continuously improve our programs. The AUA is accredited by the ACCME and designates this live activity for a maximum of 1 AMA PRA Category 1 credit. Though the AUA is not accredited to offer credit to participants who are not MDs or DOs, the AUA will issue documentation of participation that states that the activity was certified for AUA PRA Category 1 credit. Evaluations are very important to us. Course evaluations and CME credit will be administered electronically on AUA University immediately following the live program. Course evaluations are read carefully by AUA staff and faculty members and are used for our ongoing needs assessment. At the completion of the webinar, you may access the follow-up assessment, course evaluation, CME credit claim, and certificate at auanet.org/university by using a keyword that will be provided at the end of today's program. All persons in a position to control the content of an AUA educational activity are required to disclose any relevant financial relationships with any commercial interest. Please visit auanet.org/university to view Faculty Education Council and COI Review Workgroup disclosures. The AUA would like to thank the following companies for providing independent educational grants in support of this educational series: Astellas, Bayer Healthcare Pharmaceuticals Incorporated, Genentech, Janssen Biotech Incorporated, administered by Janssen Scientific Affairs, LLC, Merck, and Pfizer Incorporated. This activity is meant to be educational in nature and in some instances reflects the opinions of the presenters. Coding advice given during presentations does not guarantee accuracy of claims submitted. Please verify the accuracy of individual medical claims submitted, and please follow individual insurers' rules. We hope that you will actively participate in a variety of ways as you connect and learn from each other during today's program. The chat box is open and is an excellent way for you to communicate and engage with your colleagues throughout the duration of the program. To join the chat, simply enter your name and click the box next to the sentence, "I accept the terms of service and privacy policy." Feel free to ask questions of the faculty at any point today. Submit your questions by clicking on the blue Ask button located just below the chat box, then type and submit your question. The faculty will address your questions at the end of the panel discussion. Key points from today's webinar will be highlighted on PowerPoint slides throughout the panel discussion, highlighting important program content. So please be sure to keep an eye out for the key point slides. Finally, a big welcome today to our course director, Dr. Willie Underwood. Dr. Underwood is the director of the Buffalo Center for Health Equity and Volunteer Clinical Associate Professor of Urology at the University of Buffalo School of Medicine. He was formerly an Associate Professor of Oncology, Department of Urology, Roswell Park Cancer Institute until 2019. He received his undergraduate degree in biology from Morehouse College, Atlanta, Georgia in 1988. He received his Doctorate of Medicine and Masters of Science in Anatomy and Cellular Biology degrees from State University of New York, Upstate Medical Center, Syracuse, New York in 1994. He completed his residency training in surgery and urology at the University of Connecticut Health Center, Farmington, Connecticut in 2000. He completed a Master of Public Health degree in Health Management and Policy from the University of Michigan School of Public Health in 2004 and the Robert Wood Johnson Clinical Scholars Program in 2002. He has received several awards and honors. He received the AUA Rising Star Award and the Robert Wood Johnson Harold Amos Medical Career Development Award, just to name a few. His research interests include, but are not limited to, racial disparities in the diagnosis, treatment, and survival of urologic cancers. He received independent R01 and U54 funding from National Institutes of Health, National Cancer Institute to study race, prostate cancer treatment, and treatment decision difficulty and regret to establish the Western, New York Cancer Coalition Center to reduce disparities. He has co-authored over 100 peer-reviewed publications, published abstracts, and book chapters. Dr. Underwood is a community and healthcare leader. He is a previous member of the Council on Legislation for the American Medical Association and the AUA Public Policy Council. He is the past president of the Erie County Medical Society and is on the board of Highmark of New York Incorporated and the American Medical Association and the Joint Commission. I will now turn the program over to our course director, Dr. Underwood. Welcome.
Yes, thank you very much for that wonderful introduction. Before we begin the live panel discussion, please participate in a brief knowledge assessment. The results of these assessments helps the AUA measure the educational effectiveness of this live educational activity and aid in the successful planning and development of future activities. The first question is, which one of the following statements is true regarding shared decision-making? Shared decision-making is a non-collaborative approach to patient care that seeks to give total control of decision-making to the provider. B, this approach is independent of the patient's value or preferences. C, randomized clinical trials for shared decision-making versus routine care have demonstrated that patients engaged in shared decision-making are more knowledgeable, have more realistic expectations, participate in more in the care process, and frequently arrive at a decision aligned with their personal preferences. D, Blacks and whites have experienced the same quality of patient-physician interaction and shared decision-making. Please click the vote button now for participants in the poll. Question 2, which one of the following statements regarding the implementation strategies for using shared decision-making in clinical practice is correct? A, multiple factors affect the health and the healthcare received by disadvantaged populations. Not all Black people are the same. B, in some decision contexts, for example, it may be important to use patient decision aids to help patients consider how attributes of their neighborhood and built environment figure into their decision making. C, If the purpose of the patient decision aids is support high quality shared decision making, then the cancer care continuum, as an example, do a wonderful job of achieving that goal by addressing only educational and or health literacy when developing tools for patients who face multiple social disadvantages. D, the strategy of promoting racial ethnic concordance to improve processes of care and outcome for minorities has been extensively studied with mixed results. The underlying assumption is that people are able to better identify with others who look like them or share similar language or culture. Please vote. Which one of the following statements is not a recommendation for improving shared decision making? A, spend time discussing and explaining options. B, ask patients questions about their preferences, including what is important to them. C, spend one time with the patient discussing the treatment options because having others in the room have been reported to be in clinical trials to increase patient confusion and negatively impact the shared decision-making process. D, use decision coaching and patient decision aids to supplement patients' provider communications and make it more effective and efficient. Please vote now. Question 4. Which one of the following statement is true regarding shared decision making? A, physicians make recommendations for their patients with the best intentions. Therefore, it is critically important that the physicians make sure that the patient understand and follow their recommendation. B, in shared decision making, it is extremely difficult for patients, especially those of low SES and minority patients, to know their own values. Therefore, it is not necessary or required for shared decision making for such patient. C, for a decision-making encounter to be successful, patients must have permission to participate, confidence in their own knowledge and self-efficacy in using their shared decision-making skills. D, demonstrating empathy and sitting down with the patients has not been shown to improve shared decision-making. Please vote now. Learning objectives. At the conclusion of this activity, the attendees will be able to discuss the impact of shared decision-making on patients and on patient-clinician communication. Identify at least one implementation strategy for using shared decision-making in clinical practice. Incorporate culturally sensitive communication to assure quality shared decision-making and reduce biases. Our faculty today includes a discussion that includes Dr. Otis Broadley, Jr., MD. He's a Bloomberg Distinguished Professor at Johns Hopkins University in Baltimore, Maryland, and Dr. Calvin Moses, MD, PhD, Associate Professor Urologic, Vanderbilt University Medical Center, Nashville. And Dr. Otis Broadley, I'm sorry, I didn't mention the fact that you have an MACP as well. All right. Let's get started. Well, before we get started, first of all, now it's my pleasure to introduce our subject matter experts in joining us this afternoon. Dr. Broadley is a Bloomberg Distinguished Professor of Oncology and Epidemiology at Johns Hopkins University. He is an authority on cancer screening, prevention, and leads a broad interdisciplinary research effort that is concentrated on the appropriate practice of evidence-based medicine, efficacy in healthcare, and waste that occurs when there's not orthodox interpretation of science. Broadley is an elected member of the National Academy of Medicine, a fellow of the Royal College of Physicians, a fellow of the American Society of Clinical Oncology, and a fellow of the American College of Epidemiology, and one of the few physicians to be named a master of the American College of Physicians. Dr. Broadley was the Chief Medical and Scientific Officer of the American Cancer Society from 2007 to 2018. He is a graduate of the University of Chicago Pittsburgh School of Medicine. He completed an internal medicine residency at Case Western Reserve University and a fellowship in medical oncology at the National Cancer Institute. He is board certified in internal medicine and medical oncology. Dr. Moses is an associate professor of urology, fellowship director of urologic oncology, and director of the Comprehensive Prostate Cancer Clinic at Vanderbilt University Medical School. He is a Phi Beta Kappa graduate of the Morehouse College and received his MD and PhD training at the Baylor College of Medicine. He completed his urology training at Emory University, followed by a fellowship in urologic oncology at Memorial Sloan Kettering Cancer Center, where he served as the chief administrative fellow. His clinical practices focus on advanced prostate cancer, including several clinical trials, as well as surgical management of advanced renal, penile, and testicular cancers. Dr. Moses' research is focused on addressing health disparities in urologic cancers, determining the role of health literacy and patient interaction with the healthcare systems, and the optimal care of patients with metastatic and/or castrate-resistant prostate cancer. We're going to move on into the first segment, which is the impact of shared decision-making on patients, on patient-clinician communication. Before we get started, I'm going to start with a story that I think may be helpful bringing this segment together. Had a gentleman who come in who had Gleason 7 prostate cancer, 4+3. He had multiple core positive, and I was concerned that he should definitely receive treatment. However, but based upon his age and my understanding of his health status, I thought that radiation would be a better treatment for him. However, he desired surgery. After surgery, it was noted that he had a subclavian artery stenosis, which led to him being transferred to another hospital, receiving treatment, and also placed on anticoagulation. We're talking about post-op day number 1 of the surgery, which of course led to him bleeding and other complications, which required us to change out his catheter to a larger catheter, which is very fresh anastomosis, which led to a whole series of complications. And of course, I felt miserable by his outcome. Later on, when he came to see me in follow-up, He looks at his wife looks at him, and this is what he says. He says, I know that you didn't want to operate on me, and I know you're very upset at the outcome, and you're really concerned about me because I spend many nights next to him in his hospital bed. He then went on to tell me this. He said, listen, my brother-in-law, her brother, had radiation, and the side effects of radiation was so miserable that he committed suicide. And it was no way that I was going to have radiation. Now, here's my problem, is that I didn't know that prior to making the decision to operate. And also, I was not aware of the fact that he had a subclavian artery stenosis, which he actually was aware of it. So I put that in context of what we're really actually doing here. And the goal is to get to the best outcomes we can for the patients. So we're going to start off here. What is shared decision-making, Dr. Brawley? Did we lose Dr. Brawley?
Yeah, I think he dropped out there a second. I can feel that if you want me to.
Please, Dr. Moses.
So shared decision-making is really about a collaborative effort. And the approach should be between the patient and the physician. And your goal is that you're improving the quality of medical decisions that are made by the patient by helping them choose options that are concordant with their view, with their values, and in accordance with the best scientific evidence. And so really what that means is in a discussion with the patient, you provide information in a way that they can understand it, but you should also get information from the patient about, what's important to them, and then help the patient come to what is going to ultimately be the best option for their management.
Thank you. So when should we use shared decision-making? I'll go back to Dr. Moses, and I'll come back to Dr. Brawley.
Welcome back, Dr. Brawley. It really should be used throughout the interaction. And so obviously your initial consultation is assessing the problem and seeing what is needed. Is it medical treatment, surgical treatment? But it's really a collaborative process between the patient and the provider. And you should provide all the options. I think a lot of times Black patients, when they are seen in hospitals, clinics, they feel like not every option is being provided to them, or sometimes not even available. But really want to talk about all the options that are clinically acceptable for their condition. And it should be a continuum throughout your management of whatever problem brings them to you.
Thanks for covering for me, Dr. Moses. I totally agree. This approach is relevant in health conditions in which the ratio of benefits to harms are uncertain or equivalent or preference sensitive. That meaning that it depends on the values of the patient. In prostate cancer, both prostate cancer screening and prostate cancer treatment, and in other diseases where simply the benefits and harms are not exactly known. It's an effort to befriend the patient, involve the patient in decisions about their own care. And it's a movement away from paternalism. It really respects the patient's concerns.
Mm-hmm. So what is the point? I mean, you may have answered this, but what is the point of shared decision-making? I'm going to throw that to Dr. Moses.
Yeah, the real point is that it really improves quality of care, right? It improves. I don't like when we talk about customer satisfaction, but it does improve sort of their interaction with physicians. It also helps make quality medical decisions because it helps patients choose the options that are concordant with their values, along with the best scientific evidence. And so that it really optimizes your interaction as well as their outcomes.
That is key. So going back to the story that I started this segment with, there was a disconnect there, right? Mm-hmm. So when we look through what shared decision-making is, when should we use shared decision making and the point of shared decision making, it failed. That process, that decision process failed, and it failed. And I take full responsibility for that because I may have missed a couple questions that I should have asked. Although I believe we were connected, and I think we were, but there was clearly some signs there in retrospect where had I probed a little deeper, I may have gotten the information that I needed so that as a team, we could have moved forward the optimal outcome for the patient. Because in the end, he didn't want the complications that he received, and he also wanted care so that he can get his prostate cancer treated. The segments are the key points. Why should we care about shared decision-making? Shared decision-making is a collaborative approach to patient care that seeks to improve the quality of medical decisions by helping patients choose options concordant with their values and in accordance with the best available scientific evidence. This approach is relevant in health conditions in which the ratio of benefit to harm is uncertain, equivalent, or the preference sensitive, e.g., dependent upon the value of the patients may assign them. For example, men diagnosed with localized prostate cancer.
Randomized controlled trials of shared decision-making versus routine care have demonstrated that patients engaged in shared decision-making are more knowledgeable, have more realistic expectations, participate more in the care process, and frequently arrive at decisions aligned with their personal preferences. And I would add, decisions that they're much more comfortable with.
Yeah, and that really is highlighted in the interactions that Black patients face in the medical system. As we know, in medicine, we're not quite as diverse as we should be or need to be. And there's also historical basis of racism and segregation within medicine, the after effects which we still live with. And so a lot of the Black-white disparities we see not only in healthcare, but just in medicine in general, are reflected in the quality of patient-physician interaction. It really negatively impacts decision-making. And so that's why really focusing on the patient's value system, providing all the options, really improves decision-making process for Black patients.
And it also improves outcomes, right?
Absolutely.
So as we move forward, eliminating health inequities, this is a major step or a major component of that process. So we're going to move into segment 2. So we now move into the next segment, identifying implementation strategies for using shared decision-making in clinical practice. Can shared decision-making make strategies work in Black patients as it does in white patients?
I would say absolutely. Matching the race and ethnicity of patients. Let me back up. I have seen several times when you really try to talk to the patient, try to understand where the patient is coming from, the patient will open up to you, and the patient will want to learn more about their disease, and the patient will actually be much more comfortable with the decisions that are made. They oftentimes will go with the doctor's decision, by the way, but they're more comfortable accepting the doctor's decision about patients or doctor's decision about treatment. Now, matching the race and ethnicity of actors and models to that of the intended audience is a commonly used strategy in tailoring patient decision aids for disadvantaged social groups.
Mm-hmm. Yeah, I'll follow up on that. In fact, there's a study by Volk and colleagues where they had a multi-ethnic, blue-collar cast, as you would say, so a cohort of people acting as patients. And they tailor the main character to the viewer, so the patient is sort of the test subject. So they tailor the main character to the viewer through a series of questions that were completed upon entering the program. The program included values clarification, social matching exercises, and then they asked the patient, pick who is most like you in regards to their feelings about prostate cancer screening. This is a prostate cancer screening trial. And the results are interesting, and there's several other studies that have examined sort of this dyad of patient and provider. And really the results are somewhat mixed, but the underlying assumption is that people who are able to better identify with others who look like them, share similar language, share similar culture, are able to communicate better with their patients. And so that it means two things, really. Number one, we need to diversify, obviously. We need to have more Black, Hispanic, LGBT physicians in order to communicate with patients. But number two, it doesn't exclude or excuse a white physician from having these types of interactions. A lot of places are implementing cultural diversity and cultural understanding so that every physician should at least be able to communicate with patients and provide them with their best options so that any patient can come up with the best options for them.
You're so right. Reflecting racial, ethnic diversity of target audiences in patient decision aids is most certainly an important patient engagement strategy. However, it's also important to recognize that heterogeneity exists within racial and ethnic groups. All Blacks are not the same. All Hispanics are not the same. All whites are not the same. And I agree with you, Dr. Moses. You can be white and communicate with people of other races and ethnicities and do good shared decision making. You don't have to have Black doctors only for Black patients, although we do need we need much more diversity in the doctor population for sure. But we still can have patients working with doctors of other races and ethnicities. And because we're talking about urology, I'll also add gender.
Mm-hmm. Absolutely.
Dr. Moses, anything you want to add to that?
Yeah, I would say the point, we've made it twice now, not all Black people are the same, not all Hispanic. We had in one clinic, I have a patient Black gentleman who happens to be a federal judge here in the state. And we share a little bit of similar background as far as college and fraternity and things like that. So my resident who's with me, he always sort of marvels about the discussion and the handshake and, but the discussion was on a level, again, where because of our similar backgrounds, we were able to get to that. But then in the very same clinic, I have a long-term patient of mine who is, intermittently unhoused, uninsured. His common refrain is, "Hey, doc, whatever's best, you do it." But again, that conversation, I've never been unhoused in my life, but I know plenty who have been, including in my own circles. And so we're able to have a similar conversation. I still dap him up just like my judge, but because I can approach him on his level and explain things to his understanding, with the judge, I'm using all the SAT words and he's getting it. With my unhoused guy, I have to use some slang, a little bit of colloquialisms, but we ultimately, get to the same place.
You're talking about something that's really, really important. It reminds me of my uncle who helped put me through school. He had a very good relationship with a white physician. I remember talking about this when I was a teenager. And the reason that they got along so well is I'll never forget my uncle saying, when I talk to him, I can sense that he cares about me. Mm-hmm. The fact that he cares, and it's conveyed through respect, it's conveyed through how you talk to people, and it's really respecting people's decisions when we talk about shared decision making.
Right. People don't care how much you know till they know how much you care. And
That's exactly right.
there's an element I'm going to throw in here. We talk about diversity or improving diversity among the healthcare system. It also allows our colleagues to learn from other people who have various backgrounds and various information and stuff like that, right? We all learn from each other as physicians, and the more diverse that workplace is, the more everyone is enhanced by the process. So that's extremely important. All right, so I think so can shared decision making address the influential factors in treatment decision making?
Yeah, multiple factors affect the health and healthcare received by disadvantaged populations. A lot of factors go into it. It's just not what you know and making a decision. It's transportation, it's family issues, it's other problems. Doctor really needs to try to get to know the patient, try to understand their patient. Shared decision making is certainly a very, very big part of this, but you need to take into account all of the social issues that the patient has.
Mm-hmm. Yeah, I agree totally. My residents, I tease them a little bit. I always ask them, "Hey, where's the patient from?" They'll give me the whole story. It'll be a beautiful H&P and a plan. I say, "Where's the patient from?" "Oh, I didn't ask that." I said, "Well, we need to know that. Are they coming from a rural area? Are they coming from Kentucky? Are they right down the street? How did they get there? Who's in the home with them?" We've learned through COVID. Blacks are much more likely to live in higher density areas, have more people in the home. So I want to know where are they going if I operated on them? Who's in the house? Is there somebody to help them? Is there somebody down the road to check with them? Some of my rural white population, the nearest neighbor might be 10 miles away. So I need to know, hey, is there somebody checking on you? So those are things where I think it helps put patients at ease too. Like, I'm checking on not just their cancer, but their overall quality of life, because there's things that we as physicians do can put people in a real bad situation. And so we need to know how we are impacting that and who can assist them.
Yeah. If the purpose of patient decision aids is to support high quality shared decision making, the cancer care continuum, as an example, addressing only education and or health literacy when developing tools for patients who face multiple social disadvantages really does fall short of that goal. I'll never forget going to tumor board where we were deciding on treatment of various people, and we had incorporated navigators into our clinic. These were people who help move the people through clinic. And one of the navigators spoke up after we came up with a treatment plan for one individual and said, that may be a very fine treatment. That might be very, very appropriate, but this is why it's not going to work in this gentleman. And we had to sit down, listen to that, somewhat shocked that we hadn't thought of this, and then reapproach and come up with a treatment plan and treatment suggestions that really did fit into that gentleman's lifestyle.
Mm-hmm. Yeah, that's extremely important. And that's sort of connecting with the patients, having a dialogue, understanding, but taking it to the next level and really thinking about that individual situation at home, right? I often tell people this, that when I was younger, we had a huge extended family. We had limited financial resources, but we had human resources, right? Mm-hmm. So if I was sick, my mother could go to work, my grandmother could come over, all these sort of things, right? So now you take me now, right? And I share parent my daughter. When she's with me, it's just the two of us, right? And I have financial resources, but social resources aren't really there, right? And if I was sick, and if she was sick, that would have, and luckily I have a career where I can disrupt it and take care of that. But if I worked in a situation where I was a cashier, or even some of the employees in our hospitals who are not physicians, they don't have those things. My whole life would be turned upside down, either if I'm sick or if taking care of a sick child. And I would make decisions based upon that, right? Or even if I have other children to care for at the same time. And if we don't put that into context, then we may not understand why people are doing what they're doing. And we may just assume that they don't understand, or they don't know, or they don't care, right?
Yeah.
But in fact, they do. It's just they're thinking about things beyond what we're thinking about.
Yep.
Great discussion, gentlemen. We're going to go on to segment 3. We'll now move on to segment 3 and discuss, from prostate cancer survivors' perspective, how to incorporate culturally sensitive communications to assure quality of shared decision-making and reduce biases. What are some examples of the documented outcomes that make no sense if occurring randomly? Dr. Bowler,
Yes.
experiences.
There are racial differences in the treatment of localized prostate cancer. Tremendous racial differences. There are regional differences in the treatment of localized prostate cancer. When we look at treatments for prostate cancer, for example, there are racial differences in the receipt of pelvic lymph node dissection. No reason exists for there to be these racial differences or regional differences. There's also some socioeconomic differences, by the way, depending upon insurance. Systematic review and meta-analysis was used to generate preliminary data for testing the hypothesis that healthcare disparities exist in patient experience of clinician empathy, the so-called empathy gap. After quantitatively analyzing 18 independent studies of the care measure, including more than 9,000 patients and nearly 40% being either low socioeconomic status or non-white, we found that low socioeconomic status patients had significantly lower patient-reported assessments of clinician empathy compared to patients with SES that was not low. Let me translate that into English. Poor people and Black people overwhelmingly come away from their experiences with doctors feeling the doctor was not empathetic toward me, or the doctor did not care. Middle class and upper middle class people, on the other hand, many, many more, a higher proportion, feel that the doctor was empathetic. We as a profession need to think about how we treat patients and treat them all the same.
Absolutely.
Wow. Absolutely. I'm going to tell you, that left me speechless. So do you have any recommendations to improve shared decision-making? Again, please include life lessons. So Dr. Mo-
I would, it's really simple, and we learn it in medical school. You have your OSCEs and things like that. But the first thing I tell my residents, when you go in the room, sit down. Don't stand over the patient, because it's like you're talking down. You're literally talking down to someone if you're standing up. And even when I'm in the room, I'll ask permission, but I'll sit down on the bed next to their feet, just because I want to be, eye level. So that's the first move. And then the second one is give the patient a little bit of time. We're all rushed. We have our templates. You got 15 minutes for this and 10 minutes, but give the patient just a little bit of time and let them say what they need to say. It might not even be immediately relevant, but it's something that the patient has decided is important to say, and you can use that in context. And then use shared decision-making aids. And so one example I'll use is when I'm talking with patients about, should we do a biopsy or not, and using all the different factors. And you can talk to your face turns blue, but we use the PCPT calculator online. And what it does, you put in just various information, but the graphic that is presented is actually a bunch of smiley faces. So Green smiley faces means you're in the good. Yellow means a little bit of concern. Red means, really high risk. And people can understand, if the entire sheet is green and maybe 2 yellows and 1 red, maybe I don't need a biopsy. Like, I'll take my chances if I only have 1% risk of high-grade cancer that may not even kill me. But if it comes up and there's 20 red faces and 30 yellow faces, people can understand that. So if you can, sit down, explain things well, give them graphics. I frequently will draw things out for patients. I do a lot of kidney surgery. People don't even necessarily know where their kidneys are. So I'll draw out, the entire anatomy and say, okay, here's where your tumor is, and here's what we need to remove, and this. And when you do that, the patient says, oh, okay, I get that now. Or, explaining to men, why you got to put your finger in my butt? Like, what's that all about? If I can show them a model or a picture or draw it out and then say, hey, cancers are typically on the backside of the prostate, right in front of the rectum, quick exam, boom, boom, all good. And so those type of things where you can sit down, show empathy, explain it, those are all things that improve the patient interaction.
Dr. Bradley, add anything to that?
Absolutely. Absolutely. Dr. Moses, you are so wise in what you say. I was once explained when I was a young doctor, there are things you know, things you don't know, and things you believe. When you're counseling a patient, label those things that you tell the patient as what you know, as what you don't know, and what you believe. It's fine to give a recommendation, but tell them on what that recommendation is based. Find out what the patient feels and thinks. They will have tremendous more respect for the doctor who says, this is what I know, and this is what I don't know, and this is what I believe. Many times, many patients are concerned that we are hiding something from them. But if you label those things, as I just said, you take away any thought that you're hiding, you instill trust, you get rid of the paternalism that we all need to battle. Dr.
That paternalism is kind of ingrained in medicine. Anybody who has done medicine in other countries, that's almost the standard, right? Like you basically walk in and say, this is what's getting done, and that's it. But we need to get away from that model. So as Dr. Brawley pointed out, ask the patient, what is your preference or what's important to you? And again, we're sort of framing this around prostate cancer. So, you have to ask a patient about their sexual history, their sexual activity. Is it important? Who's in the room with them? Is it wife, partner, friend, cousin, young girlfriend, older girl? You got to sort of get to what's important to them outside of that room. And then that if there's another person with them, they can help because, men, we're a little bit simple maybe. And sometimes having that partner, that spouse, that wife gives them context because, you want to maintain quality of life. You want to do cancer care, but you want to respect what the patient desires as their ultimate outcome. And we have to get comfortable with that. We have to say, I respect the fact you might not want to do anything. You may die, and that's okay if that is your desire, because we cannot impose our values on someone else. We can always give a recommendation, but we can't impose that. So, the decision aids that we have, obviously it helps to sort of supplement the discussion, but we can't supersede that direct communication and what the patient tells us.
You are so correct. So frequently we in medicine want people to accept what we think should be their treatment. And one element of shared decision making is to get away from that and accept what it is the patient actually wants, to respect the patient's decisions.
Dr. Moses, anything to add?
Yeah, I'll sort of wrap this, at least this section, and just say, for shared decision making to be quote unquote successful, number one, we need to decenter ourselves, right? Like, it can't just be about what we say. The patient needs to feel like they have permission to participate. But sometimes, and a lot of Black male patients will be very quiet during the interaction because it's almost, they don't want to overtalk the doctor and they want to be respectful, but you really want to give them permission to speak. They need to have confidence in what they're deciding and their knowledge. And one of the things that we can do to assess that is sort of the teach back method. Say, okay, now that we've gone through this, tell me what you understand about what we've said here. And, how do you feel about that? And again, that helps you get to an efficacious interaction, but also a good decision.
Yeah. Let me try to give a couple of examples of where I've used shared decision making. I'm a medical oncologist. I treat a lot of metastatic prostate cancer. I had a gentleman who came in. He had early detection, or we had thought early detection, got a radical prostatectomy, and his PSA was now rising 2 years after getting a radical prostatectomy. At that point in time, many of us, myself included, generally start hormonal therapy when it's clear that the PSA is rising. The literature to show that starting hormonal therapy early versus waiting until later when the patient has a problem due to the cancer, the literature doesn't show that early treatment is substantially better, maybe a little bit better than starting when you have a problem from the cancer. In other words, treating the number versus treating the patient's symptoms. I sat down and it took me almost 40 minutes to talk to the patient. And that's one problem, is that sometimes shared decision making does consume time. And the patient decided, my quality of life is such that I don't want to be treated with hormones now. I don't want to have the hot flashes and other things of hormones now. I am going to put off the treatment. And we agreed he could put it off for a time, and if he came back later and wanted to get treated, we could do that, or we could wait until the cancer became symptomatic. And that patient and his wife have been very happily watching his PSA rise as he's asymptomatic now for almost 3.5 years. I could have given him 3.5 years of hormonal therapy and all the side effects of hormonal therapy, but he chose not to. And in some respects, I'm glad that I told him what I thought he should do, by the way, as part of shared decision making. But I'm glad that he decided that he wanted to be watched instead of getting early hormonal therapy.
Great. So for the remaining of this, we're going to switch to take questions from our audience. And we actually have 2 questions, which I believe that we may have already answered. One was anonymous and one from Lourdes Guerreros. And I hope that I pronounced your name correctly. And that was, can you provide examples of strategies to engage underserved patients in shared decision-making? And the other one was, can you give any additional examples of how successful shared decision-making has been used in your practice? So I believe we answered it, but if we have any other examples, please let's put.
Yeah, Dr. Guerreros, if I can, I think Dr. Moses put it best. The best way to approach a patient first is sit down. Don't be standing over them, but sit down. Look into their eyes. In the pre-COVID era, I'd actually sometimes even hold somebody's hand and try to talk to them one-on-one as if they were a relative of yours, and try to convey, I care about you. That's, I think, the most important way to communicate to anyone, be they from a poor neighborhood or underserved. That's for underserved people, that is something that they're not used to getting in medicine. A doctor who's willing to take time and communicate that I care.
So I'm going to tell a quick story. So when I started my residency at the University of Connecticut, we had a huge Puerto Rican population. So on my first day in clinic, I saw, 5 gentlemen, actually the same thing. They all came in and they had epididymitis. They had been given a prescription for a 6-week course of antibiotics, and they came back. And they all came back, but none of them had taken the medication. And of course, my co-residents were upset. They were like, I don't understand. They don't follow, they don't this and that and the other. So I sat down with one of the gentlemen and I asked him, I said, look, I'm sort of confused. You came here 6 weeks ago in pain and agony. You got a prescription to treat it. And you came back on your follow-up appointment, but you didn't treat yourself. You didn't get the medications. And he said, Doc, I came today because hoping I can get another medication because I couldn't afford the one that you gave. Right now, with that question, the whole conversation changed, right? So then what we did was something was simple. We said, okay, great. Here's the deal. For every patient that came in after that, we talked to them and said, listen, I'm going to give you 2 prescriptions. One is $14, the other one's $120. The $14 one has a chance of working, but it doesn't work for everyone. But I want you to try it. And if you don't feel better in a week, I need you to figure out how to fill the $120 one and take that for 6 weeks, right? And by the way, here's a number you can call if you're still having symptoms in the next 3 or 4 weeks, instead of you having to come in and wait the full 6-week period. These are the kind of things that was shared decision-making through conversation and relationship building allows us to provide greater quality of care to individuals and also build relationships. Because what happened was that they told everyone throughout the community that to come see me, right, when I was in there in clinic, so that I can help them, right? I mean, it's just sort of, and that's sort of how, it would enhance my knowledge and also enhance my ability to help the community in Hartford, Connecticut.
So that's how you keep your patient satisfaction scores up.
Correct, which is what we're evaluated on, right, as well. So I have a comment from Michael Berry. Seed Abraham has done a study showing the same DA in reducing the major joint arthroplasty as well as insured majority of population actually increased utilization among Black patients traditionally underserved with these procedures. Maybe we're on to something. He said that. And that's true, right? We look at it. So on one hand, it decreased overutilization in one group and it improves underutilization in another group. And again, these things have been shown across treatment decision-making, across disease populations and specialists. And we can do things to improve the health outcomes.
Yeah, Willie, there's 2 phrases that I hope start being used less or certainly placed in the context. One relates to your story. We use the word non-compliance a lot, but non-compliance is much more likely to be either lack of understanding or lack of resources. Truly non-compliant patient, they just, you tell them they can afford it, they've got access, and they just don't take it. I would venture to say it's actually relatively uncommon, especially if they understand their disease process. So I hope that phrase goes away. And then underserved or minority, those phrases sort of, they almost justify the current state. And really it's about people who are overserved or overutilization. And Dr. Brawley, he's been a tremendous champion about overutilization. But really, the medical system has been skewed historically, and this isn't a history talk, but there's a long history about why we are here, how we got to this point today. So really, we need to reframe a lot of our medical conversations and our medical terminology and how we talk about patients more in the context of where the patients are compared to where we are.
Correct.
Cannot say that better. the way to overcome so many of the disparities, and we've been studying cancer disparities for about 50 years now, although a lot of people started realizing the field existed because of COVID. The way to overcome the majority of these disparities is through just understanding and caring about people and trying to address their medical issues and helping them to address the medical issues. When you look at outcomes in the military, and I've studied a lot of outcomes from different systems, there are very few black-white disparities in breast, prostate, and other things in the military health system. It's because it's one socioeconomic group, not black or white, but one socioeconomic group, and everybody has insurance and the ability to utilize that insurance. So one way to overcome some of these disparities is this shared decision-making, trying to be less paternalistic, trying to be open, accepting, and caring of the patients we take care of. Or most of us do care, but conveying that care is what we're talking about.
Correct. And also, it's something that, so in the military, everyone is a part of one team, right? You're in the Navy, you're in the Army, you're in the Marines, right? It's Air Force. I mean, they see you as a part of the Air Force, right? You're a part of the Navy, right? And if your Army sees the Navy, you might not like the Navy much, but that's their comrade in battle, right? So these sort of things eliminate and remove some of these other misperceptions or sort of concepts. I give a lot of talks in these areas, and oftentimes I hear people say, "Those people this, those people that," and I sort of tell this story. I'd say, at the end of World War II, when Japan was devastated, and they began to bring the Japanese economy back, and they got in the automobile industry, and they began to advance the building of cars and selling cars globally. They wanted to sell cars in the United States, and they also wanted to sell vehicles to Black people. So, but they weren't, because like my mother had never owned a vehicle that wasn't American made, and she was never going to buy one, right? However, I have never owned an American made vehicle, to be honest, okay? So what happened there? So what they did, that they hired people and say, listen, your job is to help us sell cars to Black people, right? They didn't say, well, I don't know what's wrong with Black people. They don't care about their car they drive. Don't they know that our car is better than that car? They didn't say any of that. They said, your job is to help us figure out how to sell our product to them. Well, if healthcare is our product, which it is, right? And we all said on our application to medical school, I want to be a doctor to help people. And you have this huge segment of the population which we're not helping, and we have not been an ability to sell our product to them, right? Which is healthcare and good health. Then it's on us to figure out how to do that, not on them. That doesn't make sense. But somehow in this industry, we have accepted that sort of mismatching of concepts and ideas that no other business would ever have done.
Yeah, Dr. Underwood, I agree with you 100%. But I'm going to take it one step further. The largest group of individuals who suffer from disparities in the United States because American medicine cannot adequately address their problems are white Americans.
Yeah, poor whites.
Poor whites. They outnumber Black Americans significantly. Now, if you're Black, you're more likely to suffer from disparities. But if you look at the American population and say, what's the race of the largest group to suffer disparities? It's white.
Right. And on that note, gentlemen, I think we're done. We've reached the end of this discussion. I think we may be over time. So to conclude the panel discussion today, thank you for attending the AUA Engagement in Prostate Cancer Care and Lives webinar. But before I do that, I want to thank some very, very special people. You have seen in front of you our panelists with our great discussion, but behind the scenes, we've had some phenomenal people that help make this happen. And I know this is not on script and they're not expecting this, but I think we have to give them a round of applause. And we're looking at Laura Dietrich, Katie Fulbright, Kateline Rubright, and Helen Schofield. They're the ones that put a lot of work and effort in bringing this together, and we greatly appreciate that. So please hang on for a moment as I turn it over to the AUA to share today's keywords. And our AUA staff, again, thank you very much.